thank you for being here, and good afternoon, everybody. It's a pleasure for me to give this presentation since we started our adventure with Salvatore something like 30 years ago, because we started with the first Italian machine, 0.5 Tesla. It was in '86, and it was a nice pioneeristic adventure. And after that period, we had also the opportunity to start 10 years ago in the early 2004 with this device we already discussed today, and we are still discussing. Let's go to the pathological categories already beautifully introduced by the previous speaker, and very generally I subdivided these categories maybe for a didactical point of view in three main conditions: disc pathology, stenosis and instability, and other. We reviewed more than 700 disc diseases, more than 500 cases of stenosis instability, and more than 100 of miscellaneous cases. Another important point from the clinical point of view, it means the real clinical impact, is, as already demonstrated, beautifully demonstrated by the cases showed by Boson before, that this machine can help us in assessing the real level of the pathology that affects the patient. In this case, we have two herniations. In the 1.5 Tesla supine position, the L4, L5 seems to be even bigger than L5S1. But if we put the patient in upright position, the L4, L5 is stable, while L5S1 becomes bigger, and it is even better detected on the axial view, where a soft herniation, a bright herniation, it means a richly hydrated, a fresh herniation, is invading the neural foramen, with a consequent, of course, a neural impingement. Let's go to the following chapter: stenosis and instability. About 40% of the patients we examined. We should subdivide again in central stenosis, vertebral instability, and of course they are not independent. We can have a stenosis that is related to instability, and the other important chapter is the segmental microinstability, which is referred to facet pathology. Central stenosis, just to remind us what happens. This is a cartoon. I build it up for my students, but it is quite useful to remind that when we go from the supine or recumbent position to upright, what happens is that in upright position or in extension of the spine, we have a flexion of the posterior longitudinal ligament, flexion, infolding of the flaval ligament, and even the disc. If the disc is degenerated, we can have an increase in the bulging of the disc itself. All these matters can dramatically reduce the central canal. So we can imagine that if we change the position of the spine, going from the supine to the upright position, we also have that the increased loading of the spine increases the folding, the anterior infolding of the posterior ligaments and the flaval ligaments, with a consequent narrowing of the central canal. And this device is a beautiful and a very elegant way to demonstrate the changes in the central stenosis. As you can see here, we go in this level from 5 millimeters in diameter to 3.9. That can be crucial when we are already in a stenotic condition in rest position. Let me remind you that the normal dimensions of the lumbar canal is around 12 to 14 millimeters. So we are here in a condition of severe stenosis that worsens when we put the patient in upright position. Incidentally, we are discussing about lumbar spine, but I just placed these two slides to incidentally demonstrate you also the easy possibility to detect similar conditions in the cervical. Here the stenosis is quite evident, but when we put the patient in anterior flexion, the stenosis becomes less pronounced. And again, here in neutral position, there is no stenosis, but the patient complained for paresthesia and Lermite sign. That means a compression on the posterior columns of the spinal cord. And this became clear by putting the patient in, no changes in flexion, but when we put the patient in hyperextension, there is an enfolding of the flava ligament that can give us the explanation of what's happening, or the compression on the posterior columns of the spinal cord. In going to literature data, we can realize that there is an overall diagnostic gain in 15% of the cases. 30% of the cases are missed in supine position, and the modification in upright position happens in more than 50% of the cases. Here we have some simple examples of the changes that happens going from the supine to upright. Here you can easily realize that there is a clear increase in the anterior splitting of the vertebral body. What is more interesting is, again, to demonstrate that this is a 1.5. I, just as my previous speaker did, I put in some cases for comparison, for your comparison, the 1.5 Tesla aside from the 0.25, just to demonstrate you that the differences in image quality that are, to my opinion, not crucial if we are pointing out our attention to the skeletal structures. If we go to the upright position in this particular case, you can realize that the anterior splitting becomes absolutely evident with the bilateral stenosis given by both the disc protrusion and the thickening of the flava ligament. In our experience, we had an overall diagnostic gain in 12% of the cases, modification in upright in 74%, and missed in supine in 25% of the cases. Here another example of similar meaning of the previous one. You can easily detect the retrolisthesis that is absolutely much more evident putting the patient in upright position. And again here another example of a post-op patient. This patient was operated with a gauge in L5S1, but the symptoms were still present after the surgery. And if you look here, you can realize that there is a rotational instability in L4 over L5, and the patient resolved his problem after having a new intervention with a blockage of the three levels, L4, L5, and S1. Facet instability and stenosis. This is, to my opinion, maybe the most important, the most crucial focus, because it's a often underestimated condition. And the best way to examine the facet instability is to put the patient in upright position. Moreover, this microinstability is, of course, difficult to be detected even by dynamic conventional X-ray and magnetic resonance in upright. Dynamic studies in upright positions are the best to detect what happens. First of all, this paper had been already cited by Boson. The fluid leakage is the main marker of a facet instability. And what happens is that very easily we can realize that there is a change in the fluid distribution inside the facet compartment. This is a very nice example to better understand what happens in degeneration with fluid leakage in the facet compartment. This is the recumbent position, fluid leakage. There is the foramen is normal or apparently normal. There is no anterolisthesis. This, of course, is the CT in which the degenerative bony changes are much more evident if compared to MRI. Let's take a look to this movie, this cartoon. What happens is that we should remind that we have several compartments in the articular joint, in the zygapophyseal joints. The superior compartment, the intra-articular compartment, and the inferior recess. If we have a leakage and an instability of the facet, when we put the patient in upright position, what we should expect is that there is a pushing, a squeezing of the superior recess, and the liquid tends to go downward, involving the inferior recess. And the consequence of this is that the vertebral body, the superior vertebral body, splits anteriorly. And this is absolutely exactly what we register here. Fluid in the facet that goes in the inferior recess, the vertebral body split anteriorly with a stenosis of the canal of the neural foramen that became absolutely evident here. And if we look at the axial plane, it is even much more evident that we have a disalignment of the facets with an impingement, a crucial stenosis of the neural foramen. We recently published a paper concerning the possibility of recognizing the so-called occult neural foraminal stenosis, which is the entity we are talking about. Occult foraminal stenosis is the stenosis that is not present in rest position, in supine position, but it becomes evident when we apply forces on the cadaver, like here, or when we put the patient in upright position. In that cases, a diagnostic gain ranging from 50 to 57 to 60% in literature had been already demonstrated, and we had absolutely a very similar or even more crucial experience in our selected cases. If you look here, you can realize that the foramen seems to be quite normal, but when we put the patient in upright position, the foramen is absolutely narrow because there is an anterior splitting of the inferior facet that goes anteriorly. And if we compare the dimensions, of course, we can realize that there is a reduction of 50% at least of the upper foraminal recess. To conclude, our experience in 10 years stated that the overall diagnostic gain in patients suffering from low back pain or sciatica is ranging from 40 to 70% of the cases. Because we can study the conditions of the spinal curvature under stress, we can reveal occult degenerative spinal disease, we can unmask kinetic dependent diseases, we can even use the MRI in provocative condition by placing the patient in the painful condition and trying to better understand what's happening in the spine. Of course, the major work is now to better define the clinical impact following what I had been discussed with you today. I thank you very much for your attention, and before going I must thank mostly Alessandra Spondiani, who is the main researcher that worked with me, and Alessia Gallucci. Thank you very much.